All right, thank you for the introduction. What inspired this project was my minimally invasive GYN surgery rotation at UNC. At that time, I really had no idea that after this kind of major surgery that patients could go home the same day. But I found that at their institution, it wasn't just a select patient population that was able to go home. It was essentially all of their patients after these big complex surgeries were able to go home on their same day of their surgeries. So I thought that was incredible, and I wanted to look more into it. And it turns out that there's a lot of data out there supporting this practice and a lot of institutions doing this. However, this wasn't being done at my hospital. So I knew this was something that I was passionate about and I wanted to implement for our patients. So in the United States, 1 in 3 women will have a hysterectomy during her lifetime, making this one of the most popular surgeries in our country. Advances in minimally invasive technology specifically have made this a very widespread procedure and appropriate for many different patients with several different ailments, such as heavy menstrual bleeding, fibroids, and even things like cancer. But hysterectomy wasn't always this safe and effective, and it actually had very humble beginnings. The first hysterectomy was performed in 120 AD by a Greek physician named Cyrannus of Ephesus. And at this time, hysterectomies were only performed vaginally and essentially had a 100% mortality rate. So obviously this was the last-ditch effort for women who had uncontrolled uterine bleeding. Interestingly, it wasn't until about 1700 years later that there were any advancements made in the hysterectomy, when a physician in England decided to do the hysterectomy through the transabdominal approach. And then it was several decades after that that advancements in anesthesia, blood transfusions, antibiotics made this procedure more safe. And then in 1988, the very first laparoscopic hysterectomy was performed, which allowed surgeons to do this surgery through less than 1 centimeter incisions, use small instruments, and have better visualization of the patient's anatomy so that more complex procedures could be performed while also decreasing the patient's risk of surgical complications. As you can see here, for laparoscopic hysterectomy, incisions provide obviously much better cosmesis, but also you can imagine that post-op pain is better controlled, and patients have lower risk of wound complications after these surgeries. Now with advancements in technology, there are even some surgeons out there that are able to perform this entire surgery through only 1 incision through the umbilicus, which essentially leaves the patients without any scars after surgery. All of these advancements have made it safe for patients to be discharged home on the same day of their hysterectomies. Even though it looks like we've come a long ways in our technology, which we have, we are still behind the times in a lot of ways. Other laparoscopic surgeries, such as appendectomies and cholecystectomies, have been doing same-day discharge for decades. And even though we have a lot of evidence in minimally invasive surgery for supporting same-day discharge, this is something that's not being universally implemented at all hospitals, including my own in Wilmington. So the goal of my project was to create and implement same-day discharge criteria for patients at our hospital, specifically because there are over 600 procedures or minimally invasive hysterectomy procedures performed at my hospital every year. And essentially before this project was started, none of them were going home the same day of their surgery. So why is same-day discharge important? This is really just one component of a larger paradigm for how we are now treating our operative patients. It's part of something known as enhanced recovery after surgery, or ERAS. Really, this is a multimodal paradigm whose main goal is to optimize patients for healing after their surgeries. There's a lot of different tenets of this, as you can see: optimizing chronic conditions pre-op, encouraging early ambulation after surgery, decreasing opioid use. But really the main idea is this: if you treat the body like it's sick, it's going to continue to be sick. Whereas if you treat the body like it's healthy, then it's going to bounce back faster. An example of this is obviously discharging patients home the same day of surgery, because when patients stay in the hospital, they are more likely to lay in their bed, whereas if they go home, they're more likely to resume normal activity sooner, which we know ultimately these patients end up doing a lot better and healing faster. So in order to illustrate the traditional model of inpatient stay after hysterectomy versus what same-day discharge looks like, I want to take you through the experiences of two different patients. So patient A goes to the hospital for her hysterectomy, and she's pursuing the inpatient route where she is admitted to the floor and she receives round-the-clock care from a nurse. She probably has a Foley catheter in place. She's receiving IV fluids. She has access to IV pain medication. And all these things may sound like a good thing, but we know now that more care doesn't necessarily mean better care. We know that the longer you keep a Foley catheter in place, for example, a patient has a higher risk of having a urinary tract infection. And if we continue to give a patient IV fluids when they could just be drinking fluids on their own, they have a higher risk of post-op ileus. And when it comes to IV pain medications, even just having IV pain medicine once in the hospital after surgery puts a patient at increased risk for opioid dependence afterwards. So for a patient who is healthy and has an uncomplicated surgery, we now know that this level of care is no longer necessary. This patient will spend the night in the hospital. She'll see the physician the next day. And as long as everything checks out okay, she'll be able to go home about 24 hours after she initially had the surgery. She'll recover there and see her physician in about 2 weeks for an appointment. Now, patient B also goes to the hospital for her hysterectomy. But instead of going to the inpatient floor, she is in PACU where she recovers for about 4 hours. At this time, she has a nurse monitoring her who will remove her Foley catheter, make sure she can void on her own, make sure she can tolerate fluids without any significant nausea or vomiting, and they'll make sure her pain is well controlled. As long as all of these things check out, she is able to go home and she's able to recover in her own bed instead of having to be in the hospital. Of course, if the patient isn't meeting these goals, then they can recover for longer, or if there's any complications, they can be admitted to the inpatient floor. Obviously now with COVID-19, we don't want more patients to be admitted than they have to because it puts them and other patients at risk for possible exposure. So I felt like even though COVID in some ways delayed my project, it put me in an interesting position where I feel like in some ways it actually helped change the culture of surgery in my program faster than I would have expected. So obviously not all patients are going to meet criteria for same-day discharge. If they have significant medical comorbidities or have complications during their surgeries, they should stay inpatient. But we know that looking at the literature that about 80 to 90% of patients do meet criteria for same-day discharge at other hospitals, including patients that are having surgeries done for cancer. So based off of what other hospitals were doing, and in combination with recommendations from our OBGYN department and the anesthesia department, we came up with 3 central criteria that patients needed to meet in order to be discharged home on the same day of surgery. First, they had to have an ASA score of 1 or 2. The American Society of Anesthesiology has a scoring system in which they categorize patients based on their surgical risk. A score of 1 correlates with a healthy patient that doesn't have any systemic illnesses, and a score of 2 correlates with a patient who might have minor illnesses, which in the scoring system puts things like obesity, hypertension, and well-controlled diabetes in this category. Patients must be less than 70 years of age, and they must have a supportive care person available when they go home for the first 48 hours after surgery. This is so the patient doesn't overexert themselves, and if there's any reason they need to get to the hospital, they can have reliable transportation there. So I initiated this project in June of this year. Since that time, we've had 72 patients successfully discharged home on the same day of surgery, which is now about 24% of our minimally invasive hysterectomy patients. There was initially some concern that patients discharged home on the day of surgery were going to have significantly more pain because they're not candidates for spinal anesthesia or IV pain medication like the inpatients are. But we found that this actually wasn't the case, that both groups, at least for their first pain scores after surgery, their pain was relatively well controlled. We've also found that so far, none of these patients have been admitted during the 30 days after their surgery, which implies that this criteria is safe and has been effective for patients. As far as future areas of research go, we have received verbal feedback from surgeons and patients that they like this option for same-day discharge, but we have really had no way to objectively quantify any of this. So in the future, we've talked about creating surveys or possibly focus groups or department meetings with the surgeons and hospital staff in order to provide feedback on this criteria so that we can make it better in the future. We know that by looking at data from other hospitals that there's significant cost savings with same-day discharge. In some studies, they cite approximately $2,000 per patient per day that is saved when you discharge patients home the same day. But we don't have any of this specific data available for our hospital. So this is something I think would be important to look into in order to maybe get patients or surgeons who are on the fence about this, just give them an argument for why this might be important or might be something they'd be interested in. And then lastly, and possibly most importantly, like everything in healthcare, there are unfortunately socioeconomic barriers that are difficult to overcome that might make this option not feasible for some patients. You can imagine that the distance lived away from the hospital, a patient's access to reliable transportation, or their ability to speak English would all impact a patient's decision to do same-day discharge. We haven't specifically looked into these things yet, but we plan to in order to find ways of possibly overcoming this so that we can provide better health equity for our patients in this area. Lastly, I just want to acknowledge the following individuals. This project would not have been possible without them, and I thank them very much for their help. I also want to thank the Leadership College for the mentorship, the opportunity to participate in this program. I have learned so much from being here, and just to echo what everyone else said, I've just been very impressed that you've still been able to provide all the opportunities you have for us, even in this time of COVID. So I just thank you all very much for being here, and I'm definitely going to recommend this to my co-residents in the future.
Thank you so much, Dr. Warta. We do have a couple minutes for questions. Dr. Slaughter had to go to clinic in California, but we can definitely send questions to him. But it looks like we have a question from Dr. Reeder. What has been, for Dr. Warta, what has been the early feedback from patients about the same-day discharge approach? Seems that a major surgery should get a little time in the hospital. Do you have a comment, Dr. Warta?
So patients, and we have no formal way of assessing this, but just verbal feedback that we've received from patients is that they've been very pleased with this. It's actually, I was a little skeptical at first too, because it is such a major surgery. It seems like patients would be really hesitant about going home. But even when we first put out the option for this, there were many patients who were very enthusiastic about signing up for this. And I think it's because to us, the hospital might not be a scary place, but to patients it is, especially now. And I think that a lot of patients are more comfortable recovering at home. So I think that as long as patients are healthy and their pain's well controlled after surgery, which surprisingly a lot of patients have not had a lot of pain issues immediately afterwards, they feel very comfortable going home. I'm not aware of any negative feedback yet specifically from patients.
Thank you. So in the interest of time, although this is important work, I know we have some questions, and I'll encourage you to chat with Dr. Warta through the chat. But thank you for this important project and this work and bringing it to New Hanover and the coast, and being able to bring that same day approach and learning from that. So thank you, Dr. Warta.